Hi, everyone, and thank you so much for joining us today for ALS Publication Review. Today, we'll be delving into the second publication of our two-part series on AI as it relates to ALS research. My name is Jen DiMartino, and I'm the Executive Director of ALS ONE, a nonprofit organization that was founded in 2015 to advance critical research towards treatments leading to a cure, while simultaneously providing essential equipment, resources, and a community of strength to individuals impacted by ALS and their families. It was the NEALS Information and Community Education Committee who saw a gap that existed in connecting the ALS community with the authors of important research publications, and we're extremely proud to partner with NEALS to bring you this new initiative that was launched earlier this year to amplify the important work that's being done in the field of ALS while enabling the ALS community to ask questions to gain a better understanding of the contents therein for themselves and the community at large. Today, we will delve into a publication that will come very close to home for everyone impacted by ALS, as it's surely a question that has run through the minds of all. And the publication is entitled, "What Do You Think Caused Your ALS?" An analysis of the CDC National Amyotrophic Lateral Sclerosis Patient Registry qualitative risk factor data using artificial intelligence and qualitative methodology. The publication was written by Danielle Boyce, Jamie Raymond, Theodore Larson, Eddie Kirkland, Kevin Horton, and Paul Mehta. And we are truly honored to have two of those authors, Dr. Danielle Boyce and Jamie Raymond, here with us today, along with our incredible panelist lineup, Dr. John Novak, who is a neurologist at OhioHealth, Brian Andre, who is a NEALS Research Ambassador, and Dr. Nadia Sethi, who is the NEALS PEACe Committee Co-Chair. We'll hear from each of them and a little bit about their stories in just a minute, but first, it's my honor to now introduce Dr. Danielle Boyce, who is the Principal Investigator of Real-World Experience at ALS TDI. Danielle is joined by Jamie Raymond, who is with us as well. She is an epidemiologist at the Centers for Disease Control, which we know of more casually as the CDC. Danielle and Jamie, it's our honor to have you here with us today. It would be wonderful if you'd give a brief synopsis of your publication, what drove you to write it along with your colleagues, and then we'll hear from our panelists who we all have so many questions for you, and can't wait to delve into it in great detail.
I can start. So it's actually an interesting story. So several years ago, Jamie and team approached me, knowing that I'm interested in both qualitative methods, AI, and lived experience in ALS. And as a data scientist, I do a lot of work with natural language processing. But as a rare disease mom, I have a child with a rare form of epilepsy. I'm very interested in mining the rich narratives of people with lived experience to understand more. And so Jamie and team, specifically Eddie Kirkland, who you mentioned, one of our co-authors, had done an analysis using AI tools of the question, what do you think caused your ALS in the CDC registry? And more than 3,000 participants had answered that question, and some in quite great detail. And so they were hoping to use these these AI tools to uncover themes. And they weren't quite sure what to make of it. Of the results, and a lot of them, as you'll learn, were ungrouped, and they didn't quite know what to think, and so they kind of brought it to me and asked for my opinion, and in my opinion was somebody needs to kind of read all of the comments and do it by hand and compare the results to see, you know, what is going on, why isn't the AI picking things up appropriately, and how can we improve these tools. And so from there, took me, I don't know, about 2 years to hand code all of these responses, but that's what we did. And so that's what this paper is about. Jamie?
Yeah. So yeah, basically what Danielle said, but yeah, so even a couple of years before that, we had started to look at this data, and I think there were about 12 to 1500 responses at that point. And we started looking at them, just, eyeballing them, and it was a lot. It's a lot of data. It's really rich. None of us here were as experienced in qualitative analysis or had as much background as Danielle. We did talk to the AI group at CDC a while back, and they kind of played around. We gave them a subset of data, and they kind of played around with it and that kind of thing. And so that's kind of how it grew about, where we thought, if we could pull our AI group and have them help us, and we could pull someone like Danielle, we could really try and make sense of this really important question.
Yeah, and what I was learning in my role, so I'm also on faculty at Johns Hopkins in their biomedical informatics group, and also on Tufts now too. And what I was hearing a lot was about the challenges of applying these tools to clinical notes, so physician notes, and there was not classifying things properly, and how to improve the classification using case report, like the actual reviewing of these records by hand, these manual reviews, and then comparing and then using that to upgrade and improve these models. So my thinking was, well, why couldn't we do that with patient narratives as well? And I will also say that just in the time since we wrote this, there have been so many more developments and tools in the software, even beyond, my dreams. And every day something comes out it gets better and better. But I still feel like there is a gap when it comes to the natural language of non-clinician people with lived experience. And so that's what we're trying to address here.
Amazing. I find this so interesting because, uh, you know, people do this sort of thing every day, right? I have a really bad cold. How do you think you got it? I was standing next to someone in the supermarket and she sneezed. Maybe it was her. And so, and then it really can go really heavy when you start talking about obviously things at this level that people are suffering from. And when you don't have that clear, well, I have, genetically disposed, your mind starts to wander. And yeah, there's a million reasons, I would think. So thank you for that. And I know we'll get started on the questions because I know there are many. So Brian, Andre, we're excited to have you kick it off today with your questions.
Okay. Do you want me to introduce myself or just
That would be great. Actually, yeah, if you could, apologies, I would love for you to give an overview. And we know we've had your wonderful wife on here for some of our publication reviews as well, and you have done the same for us also. So if you could give your background, that would be fantastic. Thank you.
Sure. Well, Jen is, of course, right. I have a wonderful wife. And we were diagnosed in the fall of 2016. I started with upper left arm weakness and muscle atrophy. I'd always been very athletic and active throughout my life, so it was pretty concerning. And I actually went to a friend who recommended me. Well, actually, to take a step back, I started with neurology for other reasons. I'd had a neurologist. They sent me to a neurosurgeon after taking MRI pictures, and they wanted to operate right away on my neck, thinking it was a problem with compression. So I went to a friend of ours who was a doctor. She sent me to Northwestern's ALS clinic, and I was diagnosed there. We then followed up at institutions across the country. We went on a road trip. We visited with all the big shots in the field to get kind of their opinion and to increase our knowledge in what was going on. And fortunately, I have not progressed much in all these 8 years since my diagnosis. I'm still very active. And that brings me here today. So having read the paper, these are my questions to Danielle and Jamie. So I'm not sure how to make sense of trying to fit all the qualitative answers with all their variation into the much more restrictive generalized AI categories. Why would that even be deemed helpful? And wouldn't it be better to pursue all the particulars if the data is going to be used to search for possible unknown causes or contributors to ALS?
Yeah, so yeah, that's a great question. It really helps to put this study into context too. So the thought process was that there are a number of reasons why you want to you might want to do this, and one is to improve the methods. That was a big goal for me. So to better understand the subtleties, not just for patient narratives, but also for clinician narratives as well. And so better improving our ability to detect these things is really important. And then the other thing that maybe is touched on a little bit in this question is another goal of ours was just sort of a hypothesis generation. So we recognize that there's probably going to be a lot of comments that aren't necessarily yielding, a great evidence in terms of being able to bring us to the next great discovery. But especially with certain subgroups, two in particular, military service and genetic causes, I thought there were some really interesting insights from those populations that were not covered in our quantitative questions whatsoever. And I think Jamie can probably comment on that. And so, for example, we know military service is associated with ALS, but we don't necessarily understand why. We have theories, but we don't really know what. And we don't really have these narratives, these stories from people in the military. And so the idea is to be able to uncover them at a level of nuance that in detail that would allow us to follow up these leads. Jamie, do you have any comments on this?
Yeah, so what Danielle was saying, as far as we do have a military survey, but it does ask, were you in the military? What branch were you in? Were you ever deployed? That kind of thing. But we don't go into the details that the patients are able to get at in this open-ended question, where they're able to tell us, if they thought it was a military exposure, what they might have been exposed to, or what their job was, or how long they were there, those kind of things, just giving us more detail to supplement the surveys that we currently have.
Good.
Did that answer your question?
Sure, that's helpful. Should I follow up? Should I
Sure.
keep going, or do you want to pass it along? Okay.
Keep going.
So it seems to me in any case that a far larger sampling of people living with ALS, along with a large sampling of people without ALS, would have to be subjected to qualitative analysis before any hits on environmental factors could really be discerned.
Yeah, so you're right. So I think I kind of half answered this before, but with the hypothesis generation. So we definitely are not going to get the kind of level of evidence that you would get from a properly designed large scale study that you're describing. Even a large observational study would be different. So here there's just a lot of data that frankly was not particularly insightful or helpful for this particular analysis. It's all valuable for some analysis that is being done, but in this case, there were a lot of I don't knows. There was a lot of information that we did not use, and so the idea here is to kind of say, all right, what did people say? We didn't even know if there was anything that would be different or new than what we already knew from other surveys they filled out. Like we had no idea, but in the interest of leaving no stone unturned, we did find some valuable, tidbits underneath all of this, but completely agree. You're not going to find major hits on environmental causes just through doing qualitative analysis. It would be kind of like some folks were giving very detailed narratives about their experiences in the military. That you would take to someone, which is what the plan, that we would take to someone who does military data analysis around ALS and say, oh, okay, that's interesting. Like that could be something, a lead I could follow up, or that might be validating or confirming. Maybe then take their data, all the other data they filled out, and maybe if they have data in the biorepository, and then put that together. And it's just the beginning, that's what we hope to glean from this, as well as the important contribution to methods, which I think is really what I think this paper brought out is how inadequate some of these tools are, and now we have a starting point for improving them.
Okay.
Yeah, I would just quickly add that so when the registry launched in 2010, this survey was not in the original 6. The original 6 were mostly just demographic and very basic occupation, that kind of thing. And so it wasn't until the end of 2013 that this survey was added, and it was added in the second group of surveys. I think there were 2 or 3 surveys that were added at this time. And so I think they were interested, you know, by the responses that they had gotten so far on these basic ones, of trying to learn more and letting the patients kind of tell their story if it might not be captured in those earlier surveys that didn't encompass as much as we have now. To now we have 18 risk factor surveys.
Okay, I've got one last one, and then I'll pass
Sure.
it on, if that's okay. The focus of
Sure.
the study is on people's perceptions of what caused their ALS, as opposed to discerning the actual causes, and their sense of self-blame also at having somehow contributed to the cause of their disease. Shouldn't clinicians take the time to educate their patients about the hypothesized pathways of ALS and explain that the effects of these various lifetime exposures or activities on the cellular biology are really not known?
Yeah, I think that's really an excellent point. And I assume a lot of clinicians do that, but maybe this paper will help them to see how important it is, you know, a refresher in making sure that's clear, that we don't know, that it's could be multiple factors, and they shouldn't come out of the gate blaming themselves. And one of the reasons why this was important to me is as I'm a mom of a child with a very rare and catastrophic form of epilepsy. One of the best gifts a neurologist ever did for me was when he was a baby, and the hospitalization where he was diagnosed with this condition, and the neurologist walked into the room after he had just spent time with us and left, and he came back and said, you know, this had nothing to do with anything that you did. You could not have caused this. And that is why I am able to do what I do, because I was set free from that. Now, granted, there might have been exposures that I inadvertently, you know, brought into the scenario that could have contributed to my son's illness. But what I found, and I wasn't expecting to find, wasn't looking for it, I found a lot of comments that people really blamed themselves, blamed their drug and alcohol consumption, even blamed their own healthy lifestyle. And it made me realize this needs to be highlighted too. Maybe this is just as important as any hypothesis that might be generated from these data, just for people to be reminded of this. And in fact, I had more than one social worker comment to me when the paper came out that it was validating for them, because these are the things they hear, that people are just having trouble getting past this, and then, you know, not able to, you know, live their lives to the fullest because they don't have a good handle on the self-blame component of it. So yeah, I completely agree. And I hope that is something good that comes out of this paper as well. Thank you. These are great questions. And one other thing I wanted to mention that I don't think I really hit upon with your first question also is the with regard to the analysis of the data and the AI versus by hand. AI is so much faster is the other thing.
Right.
But faster is not always better. Now, I'm old school. I've been doing this for 30 years or so. And I used to do things before AI by hand. That's how we did things in the old-fashioned way. And we have all kinds of vaccines and discoveries all made before we had AI. And so a lot of times you'll hear in every meeting I go to every week, it seems like half the meeting is about AI, and how can just now I had a meeting right before I came here. It was about AI. And everybody's interested in how they can tag and analyze these unstructured notes and all this work. And so yes, we want speed. We want to be able to use AI to categorize, but we also want accuracy. And so there is the big challenge. You know, wouldn't it be wonderful if someone could, instead of answering 100 questions in a registry, wouldn't it be wonderful for them to tell you their life story, like you would your doctor when you first start seeing a doctor and they want your whole history? Wouldn't it be wonderful if you could just tell your story, and then I run a program and it puts everything accurately into a registry? Wouldn't that be great? And then we could pick up all kinds of other things that your doctor didn't ask. And that might be those things that you don't know what you don't know. With rare diseases, ultra rare diseases, you know, we don't, maybe sometimes we don't find out what the causes are, the exposures, because we only ask those that we think might be relevant. So how are you going to get anywhere with that? So that's why these narratives, I think, are really important. But the speed can't be, you know, the quality can't be sacrificed for the speed. So thank you, Brian. That was great.
Thank you.
Thank you, Brian, for that. And Danielle, you're absolutely right. I just had a personal situation in my own family that, you know, the doctors knew, well, you know, just what you just said. You know, they knew what they knew. They knew from diagnostic tests and lab work of what they knew, but getting the backstory on it was my dad getting the backstory and his life's history and everything painted a whole different picture.
Yeah.
And you know, they were able to come at it in a very different way. So all such important information. Dr. Novak, I think that you are up next with your questions.
Okay, ready.
And if you want
Well,
to give a
Peter,
little bit history,
Yeah.
John, on you
Yeah.
know, how you got into ALS, and that would be great too.
Sure. So I'm a neurologist in Columbus, Ohio, where I work for OhioHealth and director of their ALS clinic that we started, oh gosh, probably close to 13 years ago. And I think, you know, I think you get into ALS care like everyone else does. The patients and the families are so incredibly nice. It's such a terrible disease that it really sort of, you know, is an interesting science to it. There's a lot we don't know, but then there's just this obvious, incredible human side to this disease. And it is really, you know, sort of sucks you into it. And next thing you know, you're spending 80% of your time trying to care for ALS patients. So I think that's how a lot of us get kind of sucked into this. And I will say the conversation that you guys just had and the question, Brian, that last question was definitely heard. Like this concept of self-blame causing your ALS, I will be honest, I don't think I had thought much of it. You know, like this really does sort of highlight when people sit down and get to say what they feel like caused it, that they hit on themselves so much. And I don't think I appreciated that. So for that reason alone, this is a great article and I think needs to be highlighted. I'm glad we're doing this.
Yeah.
I went
that
into this
makes
for
me
the
so happy.
technology. I was all about the technology of AI. I thought this was cool, you know, and then all of a sudden this other big piece comes at you and you're like, wow, where did that
I'm a
come
little
from?
bit of both. I'm a little bit
Yeah,
technology. I'm a lot patient advocacy. So
yeah, I really sort of, that one hits home quite a bit. And so thank you for doing that and highlighting it. But I'm going to change to the technology because that's where I was going with this in the first place. So, you know, open-ended questions are not put into surveys, right? I mean, you said it took you 2 years to go through this. This is not something we would do. You've already hinted a little bit at it, but is that going to change now? Like, is AI going to change all of this?
Yeah, I mean, really incredible just in the last few years. You know, like I said, some of the technology, I do a ton of work with FHIR data, which is fast healthcare interoperability resources, data that comes from EHR directly into a feed that you can then download and analyze. And a lot of that is patient notes. And it seems like every week something comes out that makes it better and more accurate. But again, in terms of the patient narrative, I'm not seeing it. And that is a big hole and it's not the same. It's not the same. A patient's narrative, a natural way of speaking, is not the same as looking for spots on a unstructured but kind of structured physician's note to see where the parts, you know, where it would be. That's sort of predictable how the doctor writes up the note. And especially even with EHR technology, electronic health record technology, that kind of structures the note for you sometimes. So it's easier to analyze that. I was always taught in epidemiology and data science school that you want to avoid open-ended questions, right? And we're all taught that. Don't put an other in there unless you plan to analyze it, right? And how many times have I inherited a data set over these many decades that had other response? Nobody ever analyzed it, right? Nobody ever recoded it. I'm sure Jamie has seen the same. So we're always told not to do that. And so I commend the ALS Registry team for, you know, the CDC for really trying to include this, because that's really not something that is, you know, often done. And so that in and of itself, I was really impressed when I saw that they had qualitative data. But again, who's going to analyze it? So my hope is that we can continue to develop these tools, and including some of the newer ones that I've been using since this paper came out, to help better classify what we're seeing. Jamie had a good example of this misclassification when in a conversation that we had earlier about this, where the way a person speaks is, like I said, is not the same as what a doctor might say, and it's not the same as what a model that might be trained on physician speak, or science might know how to read. And so an example I had the other day, I do work with the mitochondrial disease community as well. And I was analyzing their data, and it was a Facebook comments. And in there, this huge treasure trove of narratives from people, their Facebook comments. And one of the things that really concerns these folks is the cold feet. They have cold feet. That's something anecdotally it's bothering them. And but it was getting tagged as cold, like they had a cold, or the other way around, right? And so, cold temperature, but it was being kind of divorced from the word feet, so it wasn't really helpful. It wasn't really getting, or you're getting warmer if somebody says, and then so somebody that's interpreted as heat, patient has a heat, fever, and so it goes off in this direction. So that is the work that is being done. I am very hopeful, though, very hopeful. There's a couple of groups that are really focused on this right now, and I am just on the periphery of that. But anything I can do with this data set to now we have this is what it looked like, this is what it should be. This is what AI told us it was, but this is what it should have been. That is like gold to people who develop tools. And so that is and we knew that going into this. And so it's like many layers of the value of this work, I think. One of them is the methods, one of them is the self-blame piece, one of them is actual insights into what people think and what might have caused their ALS. But yeah, I think that we're going to get to a point where we're more willing to explore this. But patients have to be centered. People with lived experience need to be centered in this work, or it's not going to work. It's going to yield junk. It's not going to yield realistic or accurate information.
And I'll just say, coming from a different perspective, coming from a public health surveillance side, we do have a researcher data set that we use. So we have to be very careful with open-ended answers, because they can contain sensitive data that the patient, wouldn't want to share. So from our perspective, I think this survey is great. It really kind of gives us an idea and kind of gives us more information from the individual surveys. And I think it's a great addition to what we have. I'm also interested to see how some of our current surveys that we currently have, how they look in 5 years. Are there going to be different answers? Are we going to see trends that are going an uptick in something else, whereas we didn't see it before, that kind of thing? But as far as, we provide, like I said, researcher data set. So, we're definitely interested in keeping, that piece for the sensitivity piece.
Yeah, that's true. So that's another thing. It's really hard to redact massive, troves of information. So it was like that with this Facebook work that I was doing. They spent so much time redacting it just to take out people's names and sensitive information about where they might live. It's true with any data set like this, and analysis of images, qualitative reports and things. If you have like a imaging MRI radiology report, there's often names and things embedded in headers and things. So that is a challenge, because somebody could say, my father, John Smith, lived in Kentucky, and now who he is, and then the Institutional Review Board made you promise you wouldn't do that. And so that is definitely a challenge. But I can also see us just getting better at asking targeted open-ended questions, shorter targeted open-ended questions. And I to me, that's a lot of what came out of this. Like specifically, oh, you said you were in the military. What was your job? Tell me about it, right? Like, tell me details. How long were you there? What, those types of things, very targeted for researchers who have a very specific hypothesis in mind.
Very interesting. So this is almost more of a technological baseline as well, this study, to say, like, compared to the gold standard of you reviewing it over years. So would you go back to the same database? Do you go back to these same surveys, run at a different program purely, well, partly to see what other answers you get, but also just to see
Yes.
what's the percentage of unaccounted,
That's
you know.
right. That's
Okay.
exactly right. That's exactly right. So think of this as the equivalent of if you're doing natural language processing in a chart review study. So let's say you're comparing the ability of a natural language processing software to pre-analyze all of your notes for you, right? All of your patient notes for you, or a chart review. Usually that's checked against some manual chart review. So you take 10 notes and you spot check and see if it picked up accurately the pulmonary function test value or so on that it grouped in the natural language processing. So that's exactly right. Because I've gone through every single person's data and coded it. This person said genetic, but it wasn't really genetic. They said I don't think it's genetic. So AI might have picked that up as genetic, right? But no, they didn't say genetic. They said I don't think it's genetic. So that wasn't the right answer. So okay, we need to make sure we refine it next time to make sure it picks that up. Now we have this kind of corpus of actual accurate statements, the way people with lived experience actually speak about their disease. Now we know what that's like and how it's accurately coded because I did it by hand. So now if I ran using like one of these updated tools, we could run it and say, they only had about 400 ungrouped. They categorized everything else, but was it true, accurate categorization, or did it just put it in some other messy categorization system that's not accurate? Now we have that baseline. And we have just about every cause that you could possibly imagine, any risk factor covered. It was all the Diet Coke I drank, the tab, soda, all these different things. Is it a tab, like a tab on a, like what is it? Now we have it. And so we can continue building on that from there. And every disease area kind of has this. If you're living in, I'm sure Brian knows, and Nadia, you live in the disease area, you're on Facebook all the time. This is just your everyday lingo. This is the stuff that you talk about every day, to you. And so every disease group has this, in my experience as an advocate. In other areas, we all have this lingo and this vernacular. So how can we fine tune these models so that we can pick that up quickly? So a good example for my own community, my son takes many anti-epileptic medications, and one went on the market, and of course it's a rare community and there aren't a lot of drugs for us, so we all went on, all of our kids went on it, and our kids were all retaining urine. They all had this one side effect where they weren't urinating for a couple of days at a time. And we were all talking about it, and it never didn't really occur to us. It's because we were all prescribed the minute this drug went on the market. We all went out and got it. And this was going on. We were all going to our physicians and what's going on? I don't know what's going on. They're retaining urine. Oh, it's probably just an autonomic thing. I had all these theories of what it could be. One physician listened to this constant narrative. We had invited them to our group to hear about it, and wrote a paper, put it in the American Epilepsy Society poster presentation. Turns out it's now a known side effect, and there's a logical reason for it based on the nature of the drug. And now it's labeled as such, and now people are warned about it. So this is the type of thing that could be useful. This infectious diseases, think about infectious diseases, how the HIV community was so helpful in understanding the transmission of HIV/AIDS. These are all the kinds of ways that this could be used.
Interesting. And I mean, I think you mentioned, going through the EHR and our notes, like if I don't put it in there, it's not going to be in there. So I need to put more narrative in there. My notes, I tend to have really short ones, and you see other docs,
yes,
long dictated notes. If AI is going to be looking at my notes someday, I need that there, or I get replaced by AI at some point.
Well, I don't think that's ever going to happen.
I hope not.
A lot of data scientists are worried about that. I think I'm safe too. So
okay.
I think you and I are good in our careers for now. But
I'm probably old enough. It won't catch up.
Yeah, but that is true. So in my life at ALS TDI, we, for the ARC study, we analyze unstructured clinical notes, and these large ones, like I said, you could populate an entire registry with all the medications and everything that they're on and everything. This beautiful history. And so that is a perfect example of the beauty of this tool. It's a tool, not a toy, though. We need to really stick to the plan, what is important, what's important to researchers, and go after that, not just play around with it because it's fun. We have to always be cognizant of the ALS clock.
Gotcha. All right. Well, let me get to my last question then. Putting them into categories, you had genetics, people blaming genetics as ranked really, really low. Like there was not a lot of people. So if we know that about 20% of folks have a familial version or an inherited version of their disease, any reasons why you think it came out so low in the study?
Yeah, so I'm going to ping this to Jamie because she might have ideas too. One thing is it does include data that's older. And so as time has gone on, there's been more awareness and testing. And so I think that could possibly have some to do with it as well. And also a lot of people, this really shocked and surprised me. A lot of people with known genetic causes or familial ALS felt it was something else. And so they might have mentioned it in a previous survey, right? They might have said, I think, or that they had a known family history and so on. But in the note, they might have said, well, I think the trigger, they might have said this, and also I think the trigger might have been an injury that I had. And I was so stunned by that when I read that. I couldn't believe my eyes. And I read it a few different comments that were like that. Like, I think actually this other thing that happened to me was why I have it, even though I have it in my family. And so as part of this member checking process that one would do for any qualitative study, you go back to usually the people who contributed the data, participants of the focus group or the interviews, but of course we couldn't do that because it was a de-identified study. So I just went to, and they're acknowledged in the paper, I went to the IMALS veterans team. I talked to a woman who had a large family history and said, is this what I'm coming up with? Does this sound right to you? And the woman from the family with many, many people said, yeah, a lot of us feel that it's not just this genetic cause, but that it's some other exposure, like a second hit, that is what brings it on. And that was such an educational moment for me. And I don't know how helpful that is to the rest of the scientific community, but it was definitely useful for me in understanding the lived experience.
Yeah. Well, also interesting. Dr. Nadia Sethi, I would love for you, first of all, thank you, John, and thank you, Brian. We'll move on now to Dr. Sethi, and if you could share your story too, that would be wonderful, and then we'll take your questions.
Thank you, and thank you so much for having me. So let's see. I am a dentist by training. My husband was a physician by training who worked in big pharma for most of his career. He was diagnosed with ALS in 2019, and we lost him in 2020. As he was going through diagnosis, I became very involved in ALS advocacy because his was a familial variant, which we came to find out. So a lot of these conversations are definitely hitting home. We wondered about Diet Coke and all of this fun stuff, and there was a lot of guilt. So I'm really glad to be having this conversation today. And that being said, we've gotten some very, very good questions from Dr. Novak and from Brian. And so I'm going to try really hard to not overlap, but it's going to be tough. So here we go. Let's see. So Danielle, I'd love to hear, we heard a lot about maybe the benefits of using AI and qualitative analysis. What are some of the potential limitations or biases that could pop up? I know we hear a lot about bias in AI, and then even some of the other questions that people answer in the registry, could those influence the responses to this question?
Yeah, that's excellent, really excellent question. So the biggest challenge for me is the natural speaking pattern of people who I study versus doctors who are using more precise language. I come from a rural community, and we don't speak the way physicians do when we're talking about disease. And we have a shorthand, and I'm sure every region has their own way of speaking, right? And it's true all over the world. And so to me, that is the biggest challenge. We like in epilepsy, you'll have a seizure could be called a lot of things. In fact, one time I was a patient advocate on a committee of neurologists who wanted me to tell them all the different ways I've heard the word seizure expressed, because they wanted to do NLP on it, and they didn't know what we called it. And it was like fits and attacks and head drops and head bobs and all, all of these things that we call them besides seizures, and certainly not tonic-clonic seizure, the formal names for them. And so that to me has been the biggest challenge. And there were other challenges that Jamie and I found, like compound sentences. Again, there are tools that have been developed that have gotten around some of that. You really have to think hard and about it and make sure you're applying these tools properly. So for example, if somebody said, well, it could have been this or maybe that, and all in one sentence, and the AI got confused, like it wasn't quite sure what to put there. And so those are the kinds of things that are most challenging. And then just a kind of a methods challenge is just, how do you know when you've subcategorized things too little or too much? When have you reached the saturation point? So there might have been, let's say, environmental exposures, but I kind of twisted that into like there's environmental and occupational exposures related to something that you're environmentally exposed to, or agricultural. Do you want to just separate agricultural exposures? Do you want to separate very specific exposure to a very theoretical exposure? Maybe the pesticides, maybe the chemicals in the water we drink. There's a lot of that, right? Maybe something in the air, versus I was sprayed with something for mosquito. I rode around on the truck, behind the truck that sprayed for mosquitoes. That's very specific. So those are some of the challenges in categorizing it. Absolutely. I think that to your question about whether other survey questions could influence it. Yeah, if this is at the end and you've just read all of these things called risk factor surveys, and you've had a lot to think about, and so you might have been reading and thinking, it asked me about, did I take statins? And it asked me, did I work with paints, or something. I don't know all the questions, but that kind of thing. You might want to put that in. From my perspective, with the kind of analysis that I was doing, that it wasn't really consequential. Because what I was looking for was how to categorize these things, and could I, and how did it match the AI work, and B, I was interested in kind of new insights. And so if they said something that had already been in the survey, then that probably wasn't going to move forward into hypothesis generation for whoever was looking at this data set later. But yeah, great question.
Thank you so much for that. And then are these surveys and data collections still going on with the CDC registry? And then is there a plan to revisit at some point and see what new additional information we can get?
Yes, absolutely. So it is still being collected. It is ongoing since November of 2013. So this is the first time we've, really dove in and looked at these answers. I would be interested to look at it, in another 3 or 4 years, and just take those 3 or 4 years and run the same analysis and then see what differences we have. Are we still seeing those same groupings? Are we seeing something new? Are the groupings changing?
Yeah.
Environmental factors higher on the list, than head injury or something like that. I'd be interested to look at the trends to see if people are seeing something different in 3 or 4 years. Maybe genetics goes up, that kind of thing. So yeah, it's definitely still ongoing, and we hope to revisit it and reanalyze the data. Absolutely.
Great. And then do you guys ever worry that families are going to worry more about what caused their ALS once they read a study like this? And then maybe this kind of fits in. What additional questions do you wish you could have analyzed?
Yeah, I always worry about that, and I try to be really sensitive. I always try to think, because we make all of our papers open access, and for a reason. I want everyone to be able to read everything that I do and understand it and talk about it like this. I want it to be very accessible, but then I always try to work like there's someone with the condition in the room. Like there's a mom like me in the room, like there's a patient with person with ALS in the room. And so I think we did a good job. Hopefully, we did a good job in emphasizing the self-blame and how that's not okay and not healthy. And we don't want people to do that. I think that was one of the reasons why I wanted to make sure I emphasize that, because I didn't want to just put in oh, here are all the things that, people think caused it, and then just leave it there and not say, but also, a lot of that is not, something they should bring upon themselves. And I think if you had just read the tables that way, like I did, I thought, you would think, oh my goodness, these are a lot of these things are things that are lifestyle, related, which could contribute potentially, like lifestyle factors. Absolutely. I'm doing a study right now, funded by the CDC with at ALS TDI, looking at risk factors, and so they could be, they certainly could be, but we don't know, and there's no way anybody could know. And then there are people who have, terrible drug addiction and, lifestyle factors, and they live to be 90. You know what I mean? So we have to always, remember that before we jump to the self-blame. But yeah, I was concerned about that, and really tried to present that in such a way that hopefully wouldn't draw attention and make people even more worried. Although I will say that if they're on in social media, they've probably seen it all. And they probably have more than their share. They're probably not telling them anything they haven't already seen. So,
And then some, yes. You're right.
And in terms of questions, I'd love to hear what Jamie thinks about this, but I think, like, if there was a follow-up, I mean, I would love to have a conversation, like be in the room with people. Like, that's one thing, is I would love there to be focus groups and be able to just have a conversation. Because I had so many follow-up questions, like, tell me the rest of the story. A couple of times I'd read this, like, oh, and then what happened? Like, I'd want to know what happened, or little detailed questions about these different exposures that they mentioned. And I wish I knew what dates certain things occurred, certain exposures, so I could go back and look at the EPA data and map it out, and all those things. So having a live person in front of me would have been really helpful. I could have a whole career, a whole entire study, let alone a career, on military exposures. I think those stories were so good. And people who are veterans, by all accounts, are great historians, and so are very good at remembering and explaining their circumstances. And so I think there really would be a value in getting in depth, even more so than we did here, on all aspects of their exposure history, to really fully understand how military service is a risk.
Yeah, that's exactly what I was going to say. I'm actually doing an analysis right now on our military survey. And so we have only about 30% of the people that completed that survey had military background. And so, like you said, like, just being able to, instead of asking, the 5 or 6 questions that we ask in the survey, what branch were you in? Were you deployed during a war? That kind of thing. It would be great just to say, okay, tell me about your military experience, and then just sit back and listen to that kind of thing. We published several years ago a paper on vigorous physical activity, and that was also limiting, because it was, we tried to define, what leisure physical vigorous physical activity was, but again, it's how do people interpret it, that kind of thing. Whereas if they had said, were you physically active as a teenager, we could have said, what did you do? And then just sit back and listen, as opposed to trying to quantify, the number of minutes a week that they did and try and determine. We don't know what kind of physical activity it was. They determined it was vigorous, those kind of things. It would be great, if we were able to get that type of information.
You're always running the risk of overburdening survey participants, and that's what the balance that you're always striking with these surveys. And over the years, since I've been involved in the rare community, I have come to really value qualitative work in a way that I never did. I didn't have a lot of respect for qualitative work when I was a biostatistician for many years, because I thought it was for people who were afraid of statistics. I didn't understand that there's a reason why you start any questionnaire development or anything with qualitative research, until I started doing it myself. So you could do a pull out of just a subset of folks, and get a lot of valuable information, for sure.
Thank you so much for that detailed answer. So I guess I talk to and I interact with a lot of ALS families, and I have for the last 5 years on social media through the NEALS Patient Education Advocacy Committee, through my work with TDI, and just be like, I've been immersed in this for 5 years, right? And just about everyone I talk to has some theory about this exact question, right? Everyone feels guilt. Everyone feels worry. I mean, I moved my kids across the country because I was scared of algae in the Great Lakes, and I moved next to a bunch of farms. So like, I don't know if I did a good thing or not, right? But we all carry this wondering what it was. So I don't know, and I know we've kind of, talked a lot about guilt already, but I don't know if you have anything else to add. And I don't think that we ever had that discussion with our clinician where they, took that off of you, Danielle, said that you didn't do anything to, I don't think that we ever had that discussion. And I think that would have been enormously helpful. So I think those empathetic approaches from clinicians can really help. And maybe Dr. Novak has some thoughts on this too, but yeah, I'd love to hear your thoughts, Danielle, if there's anything additional you have on that guilt factor and
I mean, I'm really speaking as a parent. There's no one who feels more guilty than a mother who, was pregnant and brought a child into the world who was now very sick with something and they don't know why. Of course, you're going to go there. And so that is something that it really plagued me in the early days. And I sometimes go back to it and wonder, and I'll have a little flash of the sign that was out in front of the apartment building with the spraying for pesticide when I was pregnant. Every now and then I go there. I had gestational diabetes. I was a little older, I go there, so that I think is always going to plague you. And I think though, if you partner with your clinician, your social worker, you have a good team, when you start veering off, they can bring you back, because there are a lot of temptations out there, a lot of temptations to think, the negative thoughts and think poorly of yourself. And so I believe that we need to just have an active mindset, try to have an active, positive mindset around this. And it's just basically daily work. It's always going to be there probably until they know why. But I always think to myself, is if it was so easy to know why, then we would know by now. Right? Like we would know by now. If it was one thing and it was easy then we would know. We would have it. Even with the genetic causes, we still don't quite know, right? Like we know more for them, but not everything. So if it was that simple to just have one bad exposure, you drink a glass of wine when you're pregnant, then we would have figured this out by now.
Nadia, did you have any additional questions, or did that conclude the?
Yeah, I don't want to put Dr. Novak in the hot seat, but I'd love to hear.
I'll put him in there.
But I'm going to anyway. Let's put him in the hot seat.
Well, why would you do that? What do you want to know? What part? Sorry, my dog interrupted as she was crying.
No worries. It was just like, what discussions might clinicians have with people who are diagnosed with the disease to kind of lift that guilt factor off?
I think it's probably something that we don't initiate enough. We will occasionally be asked, did this happen? Like, was it because I did this? Was it because I got head injuries? Was it because I played football? Or, and in those cases, I think across the board, we will all say, no, this is not your fault. There was nothing you could have done. But I think initiating that conversation is a big thing that should come out of this conversation, is that we need to realize that people are walking out of there thinking that, even if they didn't say it. And now they're saying it on a confidential survey, they're writing stuff about it. And so, if I, over the next year, kept track of everybody that asked me if they caused it, it would probably be this many. And then on a confidential survey, it's going to be that many. I think there's a lot of them that are carrying that burden of guilt that we need to initiate that conversation. And I think this Wednesday I have a conversation with my social worker to make sure, like, are you asking? Do you hear this stuff? To make sure that at least one of us is sort of addressing that during those patients' visits.
Yeah, I think the big challenge is that there are, like I said, there are risk factors that you might be inadvertently exposing yourself to that we don't know about. That's why we're asking these questions. So it does make it really hard. You know, you are, when you're an older person having babies with gestational diabetes, you do put your baby at risk for things like that. Is absolutely true. So helping people with ALS and other diseases understand the science and the cumulative risk and all, and to be able to translate these kind of epidemiological terms to folks, it also is important, right? So because I know you're lying when you say that this could not have been anything I knowingly, it's really knowingly did, right? Like it's not anything that I could have done. That's not exactly true, but I knew what he meant. What he was trying to say is, yes, you have risk factors, but this isn't your fault. You know, we know that this was a complicated circumstances that you could not have predicted. So I think that's also important because people can also read them for themselves and know that, well, geez, you know, head injuries and football playing and things like, you know, I'm reading all of this about this. How is it not my fault, right? And so being able to have that subtlety in your conversation about this, I think, is also important to. Otherwise, they're not going to believe you, I think.
Yeah, I think Nadia, thank you so much for sharing your story and for your great questions. I think too, just to parlay on that one a little bit, is a lot of the things now, right? They could say, oh, well, you know, like you were just saying, I did ride behind, you know, the mosquito truck, or, you know, we used Roundup in our driveway every spring and every fall. And a lot of those things we didn't know about, you didn't know about back then, that they caused harm. And so to just being able to say, but you didn't know that back then. We know things now, and not being specific, but we know things now that we didn't know back then. So can actually make people feel better. And
Yeah.
a lot of my questions have already been answered just in our dialogue. But I do, you know, one was going off of Nadia's questions about the clinicians and just, you know, are they asking questions? One of mine was about that and just how that can help the conversation with patients and families in the clinic. And we covered that quite a bit. One question that I did have was, do people ever want, do they ever follow up and say, you know, I filled out this survey, I'm just curious, what did other people say? Do you ever get those types of questions, or do they pretty much know they're just going to fill out a survey and probably not going to hear back?
So I will say, I haven't heard people respond asking what other people said, but I have had patients, you know, ask, you know, I filled out these surveys, you know, what do you do with the data? And we do try and tell them, and we're trying to do a better job. Originally, when we publish our data, we publish it open access and we put it on our website. You know, we kind of thought that was a good step in showing patients that we are using your data, we are analyzing it, and we are publishing on it. I think we need to take a step further and do a better job of maybe when we're doing the social media posts, that we are able to do something a little bit of a blurb where we can tell the patients a little bit more about the study that we're doing, and so that it's not quite in such technical wording, to try and help them understand that this isn't a policy paper, this isn't something like that. This is data that we're analyzing. You know, we've analyzed a number of the surveys already, and we're continuing, you know, to analyze the data.
Yeah, I can tell you, when I did the member checking with the ALS Veterans Affairs team, I'll never forget, as long as I live, one of the members said to me, "You're actually analyzing that?" Because when I was filling it out, I wondered to myself, who in the world is going to analyze my big paragraph that I wrote? And she said that to me, and I thought to myself, are there people walking around thinking, you know, that their ideas and their concerns are never going to be analyzed? And I can tell you, I have worked on studies before my ALS days where I would find a 10-year-old set of data and none of the narratives, all the questions that they had, none of them had been analyzed until I got there. So I know that does happen, but it really means a lot. It means a lot to the community to know that the time that they're taking to put their thoughts into this is actually going to go somewhere and be used for something. And they're okay with it not even being used for anything conclusive. They're okay with the not having the right p-value. They don't care about that. They just want to know that they're making a contribution, because they certainly are. And every person whose comment I read, I felt like it was a sacred thing that I was doing, that I was getting this insight into somebody's thoughts about their disease, and often they're very poignant. So I think that's really meaningful to share the data quickly with the community.
Yeah, I agree. I think just like you, just reading those and the impact that both of you had on it after going through them and dissecting them, and feeling your heavy hearts, just, having clinicians and researchers, everyone, just to be able to see that, to really, feel the people behind, just the field. So, I think, unless anybody has any other additional questions, everyone's shaking their heads no. So, gosh, I just thank you all so very much. This has been so enlightening. Such a fantastic way to understand, how AI is being utilized right now in ALS research. Not only obviously that, but also what people are saying. And so much of it is so poignant and so heartbreaking, and hopefully, though, can be a real value as we try to uncover, what is causing all of this. So I'm going to ask one more question, and it's a question that I ask to all of our authors that have joined us on their past webinars. If there is what would be the biggest takeaway from your publication that you hope readers will take away from it, what would that be?
I think the most important thing is that people really are listening and care what they think, period. Whether it's about their risk factors, whether it's about what they don't like about their clinical experience, whatever it is, that there are people who have dedicated their research careers to finding this out, and that the tools for analyzing this unstructured data are improving by the day. And there will be a day soon where we will be able to process your thoughts in the way that you naturally speak, and take those valuable insights and push the ball forward in ALS research.
I would just say that I appreciate every single person that goes through and answers these survey questions. We are looking at them, we are analyzing them. And at the end of the day, right now, there are more unknowns about ALS risk factors than there are knowns. So we need the data, we need to analyze the data, and we so appreciate all the patients that come through in the National ALS Registry, register with us and complete these surveys.
Yeah, there's no reason why we couldn't get the big discovery from a person with ALS. There's nothing about it. It doesn't have to come from a scientist. It could just as easily, or at least be sparked by something that a person with lived experience says to us. And so we value that. It's precious data to us. Thank you so much.
It's so true. And there's a lot of people that don't, would prefer not to take part in the clinical trials and things like that. And so to have the availability for people to participate in research in survey type of things like this is really, really important. So thank you so much for bringing and highlighting that point up as well. So this is the last webinar for the ALS Publication Review for 2024. So I just want to send my sincere best wishes to everyone for a really happy holiday season and all the very best heading into 2025. Thank you all so much for participating. So grateful for everyone on here.
Thanks, Jen.
Thank you so much. Thank you for having us. It was great. And thanks for everyone who brought their questions.
Thank you.